So I am going to talk to you about jurisdictional roles in Canadian drug access and the impact of social determinants of health. This is a very crowded space, and I'll try my best to get through this as quickly as I can, but it is complex and probably explains why it takes so long for us to get drugs into our hands. There's kind of three tiers to health management processes. There's the law and public policy, which is laws, procedures, guidelines, regulations. There are the implementation pieces to it tier, which is the health systems planning and management and health delivery. And then, if we're fortunate, there's a monitoring and evaluation process, which is the assessment of the policies and the implementation procedures that have been put in place. And hopefully, by doing so, we create a continuous learning healthcare system. So what does this actually look like? On the next slide, we have a chart that is the complex pathway to patient access. And I keep putting more things on this chart each time I do this, not by myself, but because the governments keep creating new organizations. So Dawn did a terrific job of explaining the drug development process, which is the very first box at the top. Then drugs go through Health Canada review. We now also have something called the Canadian Drug Agency. And to that point, those agencies are managed solely by the federal government. Then we move into what are called pan-Canadian agencies, and their health technology assessment and health technology agencies. And actually, there is one other federal agency, which is the Patented Medicine Prices Review Board. Then, if the drug that we're talking about is approved for sale in Canada through Health Canada and gets through the health technology assessment process, and I promise you, I'm going to describe each of these to you in more detail. Then it goes down to the Pan-Canadian Pharmaceutical Alliance, which is the provinces and territories negotiating prices and other conditions for the sale of the drug in the provinces and some federal plans together. If it gets through that process, it goes down to the provincial and territorial drug plans, and they make decisions individually about whether or not they are going to accept the recommendations to make the drug accessible through public plans. We also have, of course, over to the right side, if you're looking at the screen, we have private drug plans that have their own processes, and we have hospitals that have their own processes. So you can see it's quite a long road from clinical trial drug development that Dawn described, which is a long road in and of itself, to get it through all the processes that will maybe, hopefully, get it to the last box on this page, which is access to patients. So let's take a look at each of these, and I'll describe them to you. On the next slide, we have the question that we're going to answer here is who does what in the public sphere in health. And I'm actually going to talk a little bit of the private sphere as well. So the first thing we should take a look at is on the next screen, which shows you that this is the federal government's role in drug access. It's very important to understand, and very unfortunate, I personally think, that access to healthcare has the powers to provide it have been divided between the federal government and the provinces. I think that's created a lot of the problems that we have in access. So the federal government's jurisdiction in dealing with healthcare is ensuring universal access to doctors and hospitals. Now, under that, it doesn't say how long you have to wait for that universal access to doctors and hospitals. And we've seen through the pandemic that sometimes it's a very long time, if at all. The federal government also transfers payments for health to the provinces. The federal government collects data through its Canadian Institutes for Health Information. And as Dawn was saying, it approves clinical trials. It makes sure that drugs that get on the market are safe, effective, and of good quality. It looks at medical devices, over-the-counter drugs, and is done, also post-marketing. And they can actually remove a drug post-market if it's found to be unsafe. They also regulate the price of drugs through the organization I mentioned, the Patented Medicine Prices Review Board and guidelines. They have the power to develop a, quote, pharmacare plan, which is potentially going to be managed by the Canadian Drug Agency, although their role is not very well defined yet. The federal government manages public health policy, including pandemic policy, and it manages insurance companies' activities. So that's quite a number of things that the federal government does. And I'd just like to say that the one thing you should note particularly is what it does not do is promise to provide access to drugs. And that's except if you get it through a doctor or a hospital. Otherwise, it does not approve the sale of drugs. It does not approve the payment for drugs. That's the provinces. The federal government agrees it can be sold in Canada, and it's the provinces that decide whether to pay for it. So that's the big crunch, I think, for drug access. If we look at the next slide, you'll see that the implementation that the federal government does, they have some particular employees that they have plans for themselves, some of whom I think are on strike at the moment. Specific health strategies. We have an HIV strategy federally. We have a mental health and addiction strategy. We have a cancer strategy. We have very recently a rare disease framework, and very recently a Canadian dental care plan, all of those under the umbrella of Health Canada. And they can provide guidelines. So that's their implementation role. And thirdly is the monitoring and evaluation role, which is shown on the next slide. And basically what they do there, as I mentioned earlier, is they monitor treatments after they're on the market to make sure that they are safe and effective. They monitor excessive pricing. They transfer payments for health to the provinces, as I mentioned earlier. They collect data, and they, in infectious disease, through the Public Health Agency, they also collect data. So that's the federal government's role. And as you can see, it is very limited in a sense in relation to drugs. The reimbursement of drugs, in fact, only reimburses directly to its own plans. So let's turn to the provinces on the next slide, and let's see what they're doing. You may recall very recently that the federal government announced that it's going to be increasing health funding to the provinces and territories by $196.1 billion over 10 years. And it's also going to give immediate unconditional funding of $2 billion, especially for pediatric hospitals, emergency rooms, and long wait times for surgeries, because they were so badly, those opportunities for access were so badly smashed during the pandemic. It also, on the next slide, you'll see that in addition to that, there's going to be a 5% Canada Health transfer guaranteed for 5 years. And most interestingly, I think, is that $25 billion will be shared between the provinces with one-on-one negotiations and agreements between the federal government and each province. And they've promised that there will be 4 areas of shared priority for that $25 billion that each province is supposed to spend the money on: family health services, health workers and backlogs, mental health and substance use, and a modernized health system. So these, and the federal government has been clear that the funds that are going to be transferred to the provinces for health it will only be given to them if they continue, the provinces, to put investments into health as well. So that's very new. and how it's going to play out. We don't know what these bilateral agreements between each of the provinces and the federal government's going to contain. They may be very different province to province, and they may be entirely different. So unfortunately, I don't know how transparent they will be. So let's move on to the next slide, which talks about another part of that agreement between the federal government and the provinces that they made in February. For the first time, they set up a new role for the Canadian Institutes for Health Information, which is a federal body, and they're going to lead a process with the provinces and territories and experts to review and refine common indicators and develop a broader list for data indicators. And there are quite a few here. And this is, again, coming out of the pandemic. So they're going to look at people who have family health teams or doctors. They're going to look at surgery backlogs, new family physicians, young people with mental health and substance use services, median times for community mental health and substance use services. And on to the next page, there's a few others. People with the number of people with mental disorders who have an unmet mental health need, the percentage of Canadians who access their own comprehensive health record electronically, and finally, the percentage of family health services and other health professionals who can share patient health information electronically. This is a whole new world of a data strategy, a pan-Canadian data strategy. We never have had that before, and we have never committed to a leadership role by the federal government with all the provinces to start to build common information. That's what data is, information about people that will help us serve them better, make better public health decisions, and probably do better research as well. I guess I'll let Dawn decide if she thinks it'll do that. Next slide talks about the policy and implementation plans. So as I've mentioned, going forward, these bilateral agreements are being developed even as we speak. The rare disease strategy that was just announced recently will have to be rolled out, and the provinces will have to buy into this rare disease strategy since they also reimburse and provide access to drugs. The Canadian Drug Agency role, which we think is related to pharmacare in some fashion at the federal level, will be better defined. This pan-Canadian data management strategy that I've just talked about will start to be implemented. There'll be further engagement of government agencies, including our health technology assessment agencies, in real-world evidence, and they're even getting into limited time reimbursement recommendations. There will be increased development of pay-for-performance and risk-sharing agreements by the provinces negotiating together, so that the contracts that they make to allow the companies to put the drugs out, and the industry and the government will pay for them, the provincial government will pay for them, will not be all the provincial governments paying for them. There will be agreements that industry will pay for some. And there will also be undoubtedly further policies in mental health and addictions, cancer, and all of these areas, because we really have a really serious gaps in the needs there. So this is what I think is going to come out of what I've talked to you about so far at the federal level. It really is moving to the provincial level. So on the next slide, we see that in addition to the federal government doing particular things by itself, having complete jurisdiction, there are some things that the federal, provincial, and territorial governments do together. And one is that they have a joint reimbursement recommendation body for public reimbursement, and it's called the Canadian Agency for Drugs and Technologies in Health, and INES, which is the Quebec Health Technology Assessment Agency. So what they do, these agencies, is they look, after Health Canada's approved the drug, they take a look at the clinical data, at patient input, at clinician input, at the cost of the drugs, and they make a recommendation to the provinces as to whether the drug has enough value that it should be paid for by the provinces. It's only a recommendation. The provinces can still decide yes or no to reimburse, which is why we have drugs available in some provinces and not available in others. They also do some joint negotiations for pricing, as I've mentioned, and they are now going to be doing some joint common indicator development, health data indicator development, which I think is going to be very helpful in the long run, but it's going to take a long time for that kind of pan-Canadian data strategy to be developed. So those are the things they do together. And if we go to the next slide, we'll see what the provinces do on their own. So we've got the federal government, we've got the federal government and the provinces doing some things together, and then it comes down to the provinces in drug access. So the provinces, we often talk about are having a patchwork quilt of access to drugs across Canada, and it is that. And the reason for that is, as I've said, that each province and territory makes its own decisions about whether to reimburse drugs, and some do and some don't. They do this, they make their decisions partially on the health budgets that they develop and the drug reimbursement plans that they create. They do it through the development of special programs for particular populations, such as seniors and disease groups, and cancer and mental health being amongst those. And they also have the development of Indigenous health programming for Indigenous people off reserve. So that's kind of their framework for making their decision about whether they have the money to pay for particular drugs in their budgets and whether they want to use them to pay for those drugs. So if we look at the next slide, we see that their implementation plans, they implement all aspects of health system delivery, including the hospitals, the private clinics, pharmacies, doctors, public plans, primary care, long-term care, home care, and mental health. They have a very broad jurisdiction in health implementation. They manage the cancer agencies where there are discrete cancer agencies. They manage data for their province. They manage a huge bureaucracy. They manage clinical trials, and they implement public health measures. And now number 7 is new. They are going to be implementing these bilateral agreements in these 4 shared priority areas as of February 2023. So that's the implementation piece. And on the next slide, you'll see that they also monitor and evaluate. They do a lot of budget control to monitor and evaluate quality control. They have health boards and committees, and they have commitments in these bilateral agreements that they're going to potentially monitor and evaluate. But one of the big problems I'd like to point out is that in the agreement creating these bilateral agreements, there is no specific reference to how they are required to monitor and evaluate in each province their success in implementing these bilateral agreements, and there's no requirement for transparency of the results that they find. This is a very big problem for us moving forward. So if we turn to the next slide, so that's the public system. You have the federal government deciding which drugs can come into the country. The federal government decides if the price that the sponsor wants to charge is excessive, and if so, they have to reduce it. And then they move it to a pan-Canadian group that decides if the drugs that have been approved have sufficient value that they should be recommended for reimbursement by the provinces, and then the provinces make their decisions about drug access. So it's really a long road and quite bureaucratic. There's also private insurance, and there is an insurance act that manages insurance, and CLIA is a group that sort of represents all the insurance companies. Generally, implementation is through contracts that the private insurance companies make with employers and unions, individuals, on every aspect, including drugs, And they also work a lot with benefits consultants and human resource professionals to look at trends and what they should be considering of value to put in their contracts. And the federal government monitors them. So if we turn to the next slide, some of the trends, I've told you some of the trends that I see coming at the federal level, and some of the trends that are going to happen, I think, at the provincial level. I think we're going to see more privatization of healthcare delivery. I think we're going to see a strengthened data management system, but that's really going to take time. There's going to be, I believe, a development of more fulsome cancer strategies, the development of the implementation plans for the 4 shared priorities. I think we're going to see a reduction in public health care coverage for certain populations. We're already seeing it in some provinces. We're going to see an increased alignment between private and public coverage. Private people always bought private insurance because it gave them something better than, more than the drugs that were being reimbursed by the provinces. I think that gap is narrowing significantly, and that's a real problem for employers who are trying to use their private plans as a way of hiring and retaining employees. And there's going to be a much greater impact of social determinants of health on health incomes, on health outcomes. So if we look at the next slide, I'd just like to take a minute to talk about those social determinants of health. They are everything from the most macro things in our environment to our individual selves. So if you look at this sort of rainbow, you'll see that the purplish, blue purplish, large outer area shows us that general social and economic, cultural and environmental conditions in our lives do impact our health. And then there's the green area shows us some more specific things within that great environment that impact our health. So education, food, work environment, living and working conditions, unemployment, water and sanitation, healthcare services, income and social status, literacy, housing. They all impact health. If you don't have them, you will have poorer health outcomes. Then after that, in addition to those two, social and community networks impact our ability to have good health, because it's really important to have social supports and cultural supports when one is making decisions about health and when one has health needs. And last but not least, we have our individual lifestyle factors, such as our race, biology and genetic endowment, and culture. They can also, our age, sex, and our constitution, how we're built, also makes a big difference to our health. And we can't leave out things like racism, physical environments, and culture as being also very impactful on our health outcomes. So looking at this another way, if we look at the next slide, you will see, I thought this was a very nicely describes which of these social determinants of health has the greatest impact on your health outcomes. So 50% of your own life, your income, your education, social exclusion, the things that race, Aboriginal status, all have an impact. 50% of how you do, how healthy you are, is impacted by your life, as that list shows. 25% of your health outcomes are dependent on your healthcare. So you need access to healthcare and healthcare systems, and you can't have wait times. 15% of your ability to stay healthy is based on your own biology and genetics, and 10% is based on your environment, including air quality and civic infrastructures for people. So it's very interesting to see how which of these social determinants of health have the most impact. And it's clear that the most impact are those that are often the ones that we could do better about as a society. They are societal, and not just individual. But the others are not. So that's really important. Housing and having a social safety net, having income, having an education, all of these things impact. And our governments, provincial and territorial governments, and in some cases federal governments, do have the ability to make policies and implement them that will help with all of these problems, which in turn, such as housing and income, which in turn, food is a big one, as we know now, and that in turn will impact your 50% of your ability to stay healthy will be impacted by those things. So the government can do a lot to help us stay healthy or not let us get sick. So if we turn to the next slide, I am not going to pretend for a second to be able to speak to the issues for Indigenous populations in health. That I will just say to you that there is federal and provincial government shared jurisdiction and funding for Indigenous populations' health. Colonialism and its downstream effects have created a lack of basic determinants of health and poor health outcomes for many Indigenous populations. Indigenous populations have created principles by which they want health and anything to do with them to be created and implemented, and that is that they have ownership, control, access, and possession of whatever it is that you're doing. And so the message is, in any work involving Indigenous populations, they must be part of that work project and lead all decision making throughout that work or project. So that's all I'll say about that. That this is a, we know this is a profound and discrete stream of health issues to be discussed. And last, I would just like to talk for a minute about something that's being talked about a lot more these days, which is trauma-informed healthcare provision. You're going to start, if you haven't already, you're going to start hearing a lot more about this. So what is trauma-informed healthcare provision? It's the recognition of the impact of trauma on populations and individuals, especially those with lack of access to social determinants of health, and the provision of services to respond to that trauma in those populations must be safe and culturally appropriate. So the 6 key principles of trauma-informed approach to healthcare provision are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. And we are just starting to really understand how important these are to health outcomes. So with that, I would say I take you to the next slide, which is the question slide. If you have questions, I'd be delighted to answer them. And certainly you can always contact Save Your Skin Foundation after this presentation, and I'll be pleased to answer any other questions that you have or discuss any issues that might be of interest to you from this presentation. So thanks very much.